Good morning, everyone. My name is Dan Clauw. I am a faculty member in the Department of Anesthesiology, and on behalf of me and my co-chair, Chad Brummett, we want to welcome you to our third annual pain short course. For those of you who have come to this course in the past, this is a course that is mandated by a center grant that we have from the NIH, from the National Institute of Arthritis and Musculoskeletal and Skin Diseases. So we do this annually. The past 2 years, the course has been focused on pain research techniques, but this year we decided to focus instead on clinical care. So it's really exciting for many of us in Michigan medicine that sit more on the research side of the enterprise than the clinical care side of the enterprise to see many of you from Michigan medicine who are clinicians sign up for this course and be here for the next day and a half. We're all excited about the course and the faculty, and we think that this will be an exciting course for everyone. A couple thanks. The biggest thank, I want to make sure that she can hear me. Anytime we have an event like this, our admin, Karen Brown, is incredible, and like usual, Karen single-handedly organized everything about this conference. Karen is the most amazing admin ever, the world's best admin. And I'd also then like to thank, obviously, the NIH, as well as the Department of Anesthesiology for support of this conference. And this will work. So I'm also the first speaker. I will make sure that I get done early so that then I can chide the subsequent speakers this afternoon to make sure they stay on time. Because we have a lot of interesting talks, and I'm sure a lot of people will feel a pressure to spend more than the half hours they were allotted, but that will be at their peril because I'm going to be sitting right next to them. So. I always stop at my disclosure slide to say a couple things, and I will do the same thing here. I actually do a lot of work trying to work with drug companies that are trying to develop new non-opioid analgesics. One of the things that I should be on my disclosure slide is that I'm currently testifying in several states against opioid manufacturers because I think that what the opioid manufacturers did, starting with companies like Purdue, is evil. They knew that opioids didn't work nearly as well as they made them out to seem, and they knew that they were a lot more dangerous than they made them out to seem. And that's the basis of a lot of the litigation. It's not what we're here to talk about, though. What I want to talk about, though, is the sort of how the pendulum is swinging back and forth in the field of chronic pain. You can look at me and you can tell that I'm old. So I was trained before it was a good idea to use opioids to treat chronic pain. And that's a big advantage for me scientifically because I literally, having first been trained in the era where we only used opioids if everything else failed, and we generally thought that it was a bad idea to use opioids to treat chronic non-cancer pain. Starting in the mid-1990s with Purdue and then literally a cartel that followed, the opioid manufacturers convinced prescribers in the United States that opioids were effective to treat chronic pain, were safe to treat chronic pain, and they made treating chronic pain a lot easier than it really is because it was a lot simpler for someone to walk in the office and write out a prescription for an opioid and sort of cover up that person's problem rather than dig in and figure out what it is that you could do to really make that person better. So now, as the pendulum swings away from opioids, I had the pleasure of being on the Health and Human Services Pain Management Task Force, which just released its final report about a week or so ago. And although I and other people on the committee were not entirely happy with the report, because a report like that is at some level a compromise, it was easier on opioids than I am on opioids with respect to some of the language in the report. But having said that, I think the report will be tremendous for the field of chronic pain because a big component of the report was chiding third-party payers, starting with CMS, and then later other third-party payers, to start reimbursing for the non-pharmacologic therapies that we'll talk a lot about in the course of the day that have really now, the pendulum is swinging towards those therapies being sort of the preferred first-line therapies for individuals with chronic pain. And again, I hope that we will rapidly move to the point that we were in the mid-1990s before the opioid manufacturers got their way, where we start again using opioids as the treatment of last resort, and we push a lot of these other therapies, especially non-pharmacologic therapies that, if you will, struggled for credibility 20, 30, 40 years ago, but for which the evidence base continues to increase, that these are the therapies really that should be front and center in managing chronic pain rather than opioids, or for that matter, any of our drugs really. If we had incredibly effective drugs to treat chronic pain, then I would be okay with those being front and center. But one of the big problems is we don't have any drug in any chronic pain state that works in better than 1 out of 3 people that take that drug. So there will always be tremendous limitations, at least with the current therapies that we have with respect to drug therapies. So any talk that I ever give on chronic pain starts with this slide. It shows 2 different individuals' knee x-rays, and it points out that even though one individual has an entirely normal knee x-ray on the left, the other individual has severe osteoarthritis where they've lost all the cartilage and they have bone rubbing against bone, that you can't see pain on an x-ray or an MRI. It turns out that if you're not an osteoarthritis researcher, you probably don't know this, but 40% of people in the United States that have an x-ray like the one on the right, where they've lost all their cartilage and they have bone rubbing against bone, have no pain. 10% of people that have severe knee pain will have an x-ray like the one on the left, where they have an entirely normal knee x-ray. So one of the things that I want to really focus on in my talk is that we also have to move away, in addition to moving away from the opioid era, we have to move away from the era where we think that all pain is occurring because of a problem in the area of the body where the person's experiencing pain, i.e., that all pain is so-called nociceptive pain. There's some damage or inflammation in the region of the body where the person's experiencing pain. Our group, the Chronic Pain and Fatigue Research Center, has been one of the leading groups in the world focusing on centralized pain, pain that is coming more so from the central nervous system in the brain. And I'm going to really focus my talk conceptually at a very high level on centralized pain, how you identify it, what the impact is, and how you need to treat it differently. But I think a lot of the themes that I'm starting to talk about this morning in my talk will be carried through a lot of the other talks. So even though 30 or so years ago when I was trained as a rheumatologist, before I morphed into being a pain researcher, I was taught that osteoarthritis was our classic peripheral pain condition, that what you saw on the x-ray or the MRI was what someone would experience. That turned out to be totally wrong. There's a terrible relationship between radiographic findings and the presence of pain or the severity of pain. And although I'm using osteoarthritis today as an exemplar, as an example for how bad a relationship there is between what you see on the x-ray and what someone's experiencing, there's not a single chronic pain condition where there is a good relationship between what you see on an x-ray or an MRI and who's experiencing pain or how severe the pain is going to be. If I wanted to use low back pain as an example today instead of osteoarthritis, the disparity between radiographic or MRI findings and what the person's experiencing would be even larger than the disparity we see in the condition osteoarthritis. But the problem is, historically, when we have seen these individuals who have pain that we can't explain or understand on the basis of an x-ray or an MRI, we've had a tendency to blame them, blame psychological factors, say it's all in your head, you're just making this up. And again, as as someone who leads a group that has been the most responsible for legitimizing conditions like fibromyalgia, we know now that a lot of pain is in fact coming from the brain or the central nervous system, and this pain isn't any less legitimate or any less deserving of treatment than pain that is nociceptive, but it requires a different approach. The drug and the non-drug therapies that are going to work on pain that is coming more so from the brain or the central nervous system are going to be somewhat different than the drug and the non-drug therapies that are going to work for pain that is coming from the knee or is coming from the area of the body where the person's experiencing pain. And this is my favorite line on this slide, where you look at the evolution of our thinking of osteoarthritis, and again, I'm old, so I can tell you about this, is that I was also taught 30 or so years ago that treatments like NSAIDs, opioids, and knee replacement surgery almost always worked in osteoarthritis. But if you look at the latest meta-analyses, nonsteroidals only work in 1 out of 3 people with osteoarthritis of the knee. Opioids are strongly not recommended at all for treating osteoarthritis of the knee. And we know that about 30% of people that have knee replacement surgery won't have improvement of their pain. So you can see that this model is flawed. This entirely peripheral model of pain is flawed in that it really doesn't explain what we see is happening in our patients. So I'm going to talk a little bit about fibromyalgia, but I'm going to talk about it more so as a metaphor than a standalone diagnosis or a standalone illness. And I always, when I show this slide, remember to tell people that call fibromyalgia whatever you feel comfortable calling it. I get that some of you think fibromyalgia is the F word and that you don't want to use that word. Use centralized pain, use whatever word you want to use, because I understand that there is some baggage clinically associated with the term fibromyalgia. But I don't really care what you call it as long as you understand it and as long as you integrate what we've learned about fibromyalgia into how you approach individuals with chronic pain. And there's a lot of things we got wrong about fibromyalgia. There's a reason that there's some fibromyalgia haters out there. One reason people thought fibromyalgia was stupid was tender points, and it is true, tender points are stupid. Because the whole person's tender. And it doesn't matter where you push. Those 18 areas of the body turned out to literally be areas of the body where everyone is more tender. And there's nothing at all magical about those 18 areas of the body. And in fact, our group was heavily involved in creating the new criteria for fibromyalgia that don't require doing a tender point count. So please stop pushing in those 18 areas of the body. And instead look really more for the fibromyalgia or centralized pain phenotype, which I'm going to talk a little bit about because that actually will be more helpful in thinking about fibromyalgia or thinking about the degree of fibromyalgia that someone has than counting tender points. But as someone who now is firmly in the international pain research community, there's really no disagreement amongst pain researchers about the validity of fibromyalgia. In fact, it is really thought to be a poster child for a third mechanism of pain that we didn't know anything about until about 20 or so years ago, until the advent of research techniques like functional MRI that Rick will talk a little bit about in a couple minutes. We didn't have any way of really knowing that the pain in fibromyalgia or irritable bowel or interstitial cystitis or headache was real, even though we couldn't see it on an X-ray. We couldn't see it on an MRI. But there's nothing that I'm going to talk about today that is in any way controversial in the pain research community, although there's certain subspecialties that still, again, would view fibromyalgia and even the thinking behind fibromyalgia as not legitimate. But it is the case that the International Association for the Study of Pain, the international organization that many of us are members of, a couple of years ago said there is a third new underlying mechanism of pain that has been identified over the last 20 or so years. Our group has historically called that centralized pain. The term the IASP is preferring us to use, which we hate, is nociplastic pain. So you will not see the word nociplastic on this slide anywhere. But again, regardless of what we call it, there's really broad recognition that it exists. And in fact, it is now thought to be the most common cause of chronic pain in people under age 50, because if you look at the conditions that are now thought to be centralized or nociplastic, fibromyalgia, headache, irritable bowel, low back pain, interstitial cystitis, endometriosis, these are all the most common chronic pain conditions in people under age 50 or so, until osteoarthritis becomes the 800-pound gorilla because it's so prevalent in people as they become older. But this slide depicts that you can actually tell the difference between these three underlying mechanisms of pain: nociceptive pain, neuropathic pain, and centralized pain, in part based on the phenotype that the person presents with. And what I'm going to talk about, and I'm sure other people will expand upon, is the centralized pain phenotype, or the fibromyalgia phenotype, that you really want to look for, because when you see that individuals have more widespread pain, when their pain is accompanied by other central nervous system symptoms like fatigue, memory problems, sleep disturbances, When you see that people are sensitive to the brightness of lights, the loudness of noises, odors, that should be a blinking neon light that this person's pain is coming from their brain or their central nervous system rather than coming from their knee or their elbow or their abdomen where they're presenting to you with pain, and that this kind of pain is going to require a fundamentally different type of treatment because the etiology is different. It's not coming from a problem in the area of the body where the person's experiencing pain. It's coming from the way the central nervous system is processing that individual's pain. So all of a sudden, you throw out the window, if someone's pain in their knee is coming from their brain, it's not likely injecting their knee or doing surgery on their knee is going to be very helpful because that's not at all the source of their pain. But it also is true that some of the drugs we use, nonsteroidals and opioids, work a lot better in nociceptive pain than they do in centralized pain. And so you have to also look at what type of pain someone has before you pull out your drug cabinet and you decide which drug to prescribe or what class of drugs you're going to give someone given the type of pain you think they have. And a point of emphasis here is that we used to think that if we knew the disease that someone had, that we knew what mechanism their pain was. So if you look at that chart there and you look at the far left column, one of the classic types of nociceptive pain is osteoarthritis. I just showed you those slides. And it is true that everyone with osteoarthritis has some ongoing nociceptive input coming from the involved joint that they have osteoarthritis in. But now we know that 30 or 40% of people with osteoarthritis superimposed on having nociceptive pain will also have centralized their pain. And if you don't pull out those osteoarthritis patients that otherwise look the same on their x-ray of their knee, if you don't pull out those osteoarthritis patients that centralize their pain and treat them differently than an osteoarthritis patient that merely has nociceptive pain, you won't make that person better because you're only treating one element of their pain. And so one of the analogies that I started using to explain this to people about 15 or so years ago, which seems to work, no one's told me that it's stupid, is an electric guitar analogy, and that the amount of pain that someone experiences is akin to the loudness of an electric guitar. Work with me here. I promise this will work. In an electric guitar, we have several guitar players at the table here, and they will affirm that in an electric guitar, there's two ways to make the guitar louder. You can either strum the strings harder, or you can turn up the amplifier. But if I superimpose these two knees here, knees, like any other area of the body, have all sorts of different sensory nerves, and different sensory nerves bring qualitatively different information from that area of the body up to the brain to tell you what's going on in that area of the body. Some nerves pick up heat and cold, some pick up pressure, some pick up inflammation, chemical signals. But just like you have different strings on the guitar that bring qualitatively different information through the amplifier to be heard as sound, we have different sensory nerves that are telling us what's going on in different areas of the body. But the primary determinant of whether that information gets up to the brain to be felt as pain is what the amplifier is set at, and the amplifier in the human body is the central nervous system. If you happen to be born with a high amplifier setting, you can be like that x-ray on the left. You can have pain in your knee even though there's nothing wrong with your knee because the fundamental problem is your amplifier was set too high. And it's akin to having a radio that is turned to a non-station and you turn the volume control up. And if you talk to the average fibromyalgia patient, it almost feels to them like they're that the amplifier is just set too loud, that everything going on around them is amplified. All sensory experiences are being amplified, including and especially their pain. But at the other side of the continuum, we also see the reason why the 40% of the people in the U.S. population that have a knee that looks like that don't have any pain, are fortunate enough to be born pain insensitive. And most of those people are men. The overwhelming majority of individuals in the U.S. population that have an x-ray that looks like that don't have any pain, are males, because on average, males have a much lower amplifier setting than females. Males feel much less of what's going on around their body than females. And so those females in the room that are annoyed at me and think I'm a misogynist, just flip this around. You've always known that males are insensitive. This is now, but the reason that women have 1.5 to 2 times the rate of any type of chronic pain than men is that women have, on average, a higher amplifier setting. Women don't have any more damage out in the periphery than men do, women on average have a higher amplifier setting, which puts them at higher rates of all pain conditions, especially these centralized pain conditions that are much more prevalent in women. This is just another way of showing a bell-shaped curve and showing that different people sit at different points in the bell-shaped curve. The more tender you are, the more pain-sensitive you are, the more pain you will have over the course of your lifetime, not because you're more likely to have a problem in your knee joint, but because the way that information from your knee joint is sensed by your central nervous system is different than the person who might be sitting next to you. If you don't like the word fibromyalgia, you'll hate the word fibromyalgia-ness. But I'd like to give Fred Wolf credit for pointing out that we shouldn't think of fibromyalgia as yes or no. We should think of it more as sort of a volume control or a continuum or an amplifier setting. And this is about the only thing that I agree with Fred Wolf about. If you look at the medical literature, he still thinks fibromyalgia patients are neurotic middle-aged women that there's nothing wrong with. But he got this right, and so I like giving him kudos for this, because it turns out that there is nothing about fibromyalgia that is yes or no, that everything that we're talking about here with respect to centralized pain is where people are on a continuum, and a lot of people with nociceptive and neuropathic pain have elements of centralized pain that can be identified and should be identified and treated in clinical practice, because you're a lot more likely to make that person better if you're addressing all the elements of their pain, not just the nociceptive elements of their pain. And so this is the new way of diagnosing fibromyalgia, by looking at how widespread someone's pain is and by looking at symptoms like fatigue, memory problems, and sleep disturbances. This is scored based on 0 to 19 points for the left side for how widespread the pain is, and then 0 to 3 points for how severe fatigue, memory problems, and sleep disturbances are. You can get a total of 31 points. And it is said that 13 or greater on this measure is diagnostic of fibromyalgia. But what most of us want to convince you of is don't rigidly look at that 13 cut point. Look at what someone's score is. And the higher someone's score is, it seems, the more that their central nervous system is contributing to their pain, and the more you should really use the drug and the non-drug therapies that would work for someone with fibromyalgia, rather than thinking that all their pain is due to ongoing nociceptive input. So I'm stealing a couple of Chad's slides here. I love this slide. Just to show the two extremes of this concept. Imagine you're an orthopedic surgeon, a well-meaning orthopedic surgeon that does surgery to make people better. There's a lot of those out there. And someone comes into you with severe knee pain and they have an x-ray like the one on the right where they have bone on bone. Are you going to offer knee replacement surgery? You should. But how much better would you think that person would get if that knee was in that body? So this is an average fibromyalgia patient. So I'm showing the two ends of the continuum because it's actually sort of intuitive that this person probably isn't going to do quite as well if we replace his or her knee as someone that might have pain in a single location in their knee. But what I want to try to convince you of is that it really, that everything is in between is really important. And the people that have centralized pain that do not carry the label fibromyalgia are much, much, much more common in clinical practice than people that are labeled as having fibromyalgia. The people who are labeled as having fibromyalgia are the tip of the iceberg. There's far greater numbers of people that their label is osteoarthritis, rheumatoid arthritis, cancer pain, any other type of pain that have the same underlying problem as fibromyalgia, but we don't call them fibromyalgia. And those are some of the people that get the worst care in the U.S. medical system because people think all of their pain is a problem in the area of the body where they're experiencing pain and don't think of sort of treating their brain or their central nervous system with all of the non-drug and drug therapies that we can use to, if you will, turn down someone's volume control. So I'm just going to go quickly through these studies that we did at U of M that Chad led, where we proposed that the fibromyalgia measure was a good surrogate measure of the degree of pain centralization. The studies that I'm going to present to you were done in people getting knee and hip arthroplasty, but we've actually done almost identical studies and had almost identical findings in women getting hysterectomy for chronic pelvic pain. But in these studies, we postulated that individuals that were getting knee or hip replacement surgery would be less likely to respond to that surgery and less likely to respond to the opioids that were administered immediately after the surgery to control their pain, and that the higher their fibromyalgia score, the less well surgery would work to improve their pain 6 months later, i.e. their knee pain, as well as the higher the fibromyalgia score, the more opioids we would need to give to control their pain in the first 24 to 48 hours after their surgical procedure. We gave them this fibromyalgia measure on the day of surgery. Again, this is how you score the measure. And sure enough, it did turn out that each 1-point increase in the fibromyalgia score made people less opioid responsive, less surgery responsive. This phenomenon was linear, like Fred Wolf said, starting at a score of 0. Going from a fibromyalgia score of 2 to 4, even if you're on the low range of the fibromyalgia measure, still made you less opioid responsive and less surgery responsive than going from a score of 12 to 14, which would flip you from being a non-fibromyalgia patient to being a fibromyalgia patient. So we strongly recommend against thinking of fibromyalgia as yes or no and thinking of it as a continuum. The other thing I want to emphasize about thinking of it as a continuum is that if you think of it as a continuum, most people who have the label of fibromyalgia have had pain for 30 years, have a lot of psychological, psychiatric, social, cognitive comorbidities. They're impossible for many of us to make better. And so when you think of fibromyalgia, you think of psychological comorbidity if you think of a fibromyalgia patient. But when you study fibromyalgia in this way, these psychological factors are not playing nearly as prominent a role in people with mild amounts of fibromyalgia, mild degrees of pain centralization, where you might just give them, get them exercising, get them sleeping better, get them doing some simple non-pharmacologic things to turn down their volume control. But not everyone has mad dog fibromyalgia that we can't make better. These are literally people that have gone 20, 30 years and have gotten inappropriate or no treatment. And that's why we can't make them better, because we actually didn't do anything during the early active phase of their disease that would have, in fact, made them better. This is a data slide I like showing from these fibromyalgia studies. This is looking at 700 or so people that got knee or hip replacement surgery at Michigan. The first thing I'd like to point out is that red line is the score of the fibromyalgia score of 13. There were 55 people as part of that study that here at the University of Michigan, that on the day of surgery, when we gave them that fibromyalgia measure, we concluded they had fibromyalgia because their score was greater than 13. Anyone practicing in Michigan medicine want to guess how many of those 55 people actually had ever been diagnosed as having fibromyalgia? 0. So everyone was looking at those people with osteoarthritis as the same. They were all the same. No one was in any way looking at them as being any different, even though when we administered that measure, we could see a lot of people met criteria for fibromyalgia. But look at 2 people that didn't meet criteria for fibromyalgia. Patient A and patient B that are both on the left side of 13. Patient A has pain in his knee and has a little bit of fatigue. That got him a fibromyalgia score of 2. Patient B has pain in his knee, pain in a couple other spots, a little bit of fatigue, a little bit of sleep problem. That got him a fibromyalgia score of 12. But look at how different these 2 people are with respect to how much opioids were needed to control their pain in the first 24 to 48 hours and whether they were going to get better after we replaced their knee. Patient A was 5 times more likely to get better with knee replacement surgery as patient B, and neither of these people has fibromyalgia as a categorical yes-no diagnosis. Again, just pointing out that this is a powerful measure and that classic psychological factors are really playing a relatively minor role, especially in people at lower parts of that continuum. So when we come back to this slide, all of our chronic pain conditions are mixed pain states. There's not a chronic pain condition that doesn't have high rates of centralized pain. Sickle cell patients, Ehlers-Danlos hypermobility patients, a lot of different clinical populations have very high rates of centralized pain, and these people are still being treated largely with opioids, which is really the exact wrong class of medications to use for centralized pain. If someone has centralized pain, finding that out doesn't tell us what isn't going to work, it tells us what is going to work. This is a study that showed that the drug duloxetine worked a lot better in low back pain patients that had widespread pain. They really used the Michigan body map, the MBM that Chad developed in some of their recent studies of low back pain, and they showed that duloxetine worked a lot better in low back pain patients that had 6 or more sites of pain, 5 or more sites of pain, were 60% better than duloxetine worked in people with low back pain with a single location of pain at just one spot in their back. And similarly, we're seeing now in rheumatology that as new drugs are being developed, this is a drug that's being developed to inject into people's knee to prevent the progression of osteoarthritis. And it only works in the other end of the continuum. It only works in the osteoarthritis patients that don't have widespread pain. The people that would have pain confined to just a couple joints, once the osteoarthritis patients have widespread pain, this drug doesn't work anymore because the pain isn't coming from the knee anymore. Literally, the pain is more so coming from the brain, so injecting the knee is unlikely to be of any benefit. So Rick and others will talk a lot about some of these cool gadgets that we have as pain researchers to infer where pain is coming from and what the underlying mechanism of pain is. But our group and others have done a lot of work using functional MRI, functional neuroimaging, looking at the degree to which different brain regions are either too connected to each other or not connected enough to each other. Even the size and the shape of the brain changes as people centralize their pain, as they have this long-standing chronification that's occurring in the central nervous system. So if you're coming to this conference and you're not a pain researcher, and you've heard people say, well, everything about fibromyalgia, it's not a real disease, there's no objective underpinnings, that's a bunch of crap. There's really nothing about fibromyalgia that isn't objective. We have a really good neural signature for centralized pain in fibromyalgia. That's why our group has so much NIH funding. That we literally, we know what this looks like. Now what we have to do is get clinicians and people where the rubber hits the road, the treating people, to really understand how to integrate this new knowledge that's occurred over the last 20 years into practice so that you can take better care of chronic pain patients. You have more things at your disposal. A lot of the non-pharmacologic therapies you probably haven't historically used as aggressively as you can and you should. And you probably also haven't been using as many of the centrally acting analgesics, the tricyclic drugs, which are still great drugs to use for this kind of pain. The gabapentinoids, the serotonin norepinephrine reuptake inhibitors, that would be the preferred drugs for people with pain that's coming from their central nervous system. Yvonne Lee, who's going to be here later, will present her data on rheumatoid arthritis. Yvonne and Neil Basu have been doing really cool work showing how fibromyalgia superimposed on autoimmune diseases can affect the prognosis and the response to therapy of people in autoimmune diseases. But, and then these are some studies that Neil will present, basically sort of looking at the neural signature of that kind of pain. But the reason this is all important is look at the drugs that work for this kind of pain. You see up down at the bottom, NSAIDs, opioids, corticosteroids, benzos. None of those drugs, now some of those shouldn't be given for any pain like benzos, but none of those drugs work at all for centralized pain. And instead, again, the preferred treatments are the tricyclic drugs, the serotonin norepinephrine reuptake inhibitors, and the gabapentinoids. Look at the next column. One of the cool new treatments for fibromyalgia is low-dose naltrexone, that we should be blocking the endogenous opioid system rather than giving these people opioids. And as I've said often, giving someone with centralized pain an opioid is like throwing kerosene on a fire. And we've actually done a series of studies over the last 20 or so years showing that in contrast to other neurotransmitters in the brain, which are sort of in the direction that you would anticipate in conditions like fibromyalgia, even though the endogenous opioid system is analgesic, endogenous opioid levels in people with fibromyalgia are quite high. They have very high levels of endorphins and enkephalins in their spinal fluid. And by the way, the drugs that work and don't work in fibromyalgia match up nicely with which these neurotransmitters that are awry. But this is an imaging study that we published a couple years ago where we did PET imaging with carfentanil simultaneous with fMRI, and it really looked as though the endogenous opioid system was driving some of the features of fibromyalgia, that the release of endogenous opioids was participating in the pathogenesis of fibromyalgia. And this is why, again, you would sort of understand why I'm saying don't give these people an exogenous opioid, because it's likely you could actually drive this process to be worse rather than doing what you're hoping to do, which is make these people better. And certainly a lot of people are going to talk about opioids, some of the problems we've gotten into with opioids today. But this is one of the slides I like showing, is that if you approach people with chronic pain from a mechanistic standpoint and you really, instead of saying, I know their disease and thus I know what drug and non-drug treatments are going to work, instead try to figure out, I know the pain mechanism, and then try to match up the treatments you're going to use with the pain mechanism, and your treatments would be much more likely to be effective because it's actually, the reason some of you are going so rapidly through your book is I hid a bunch of slides because I wasn't going to show them. So that's why the hid slides actually still shown up when they're printed. So sorry for that. So I'm just going to end here and talk about how important the non-pharmacologic therapies are in treating pain. This rehab approach, where we're actually using the rehab approach, we're trying to sort of restore, getting people back to the function that they were before they had chronic pain. We know that exercise in particular, exercise in my mind is the most effective treatment for chronic pain across all chronic pain conditions. But having said that, we probably could do better with respect to knowing what type of exercise is best for which underlying mechanism of pain. I see you're probably some PTs there sitting with, but again, we could do better. Right now, we probably, there probably are different physical therapy regimens and exercise regimens that would work better or worse for people with more nociceptive pain or more centralized pain. And these are all areas where we could do research and really help provide guidance to the broader medical community about how to best take care of chronic pain patients. But look at how rapidly some of these non-pharmacologic therapies are moving up the ladder here with respect to how effective they work. Rick Harris, I think, is going to talk in particular about acupuncture and how science has led to greater acceptance of acupuncture. Dave Williams is the architect for FibroGuide, a website that he developed about 10 or so years ago that gives people with fibromyalgia self-management techniques. He'll talk a lot about this, and I hope he's talking about the new version of Pain Guide that'll come out soon, and that'll be for anyone with chronic pain, not just people with fibromyalgia and centralized pain. I'm not going to talk about this. Andrew Schreff's going to talk about diet and nutrition. I just want to give you a sense that our group really is looking broadly into a lot of different areas in chronic pain. And then I'm going to end now by telling you, giving you an aspiration, which is that I hope some of you that are in the room that are part of, what's the process, rewrite the script process. I hope that many of you are in the room. But Michigan Medicine now is going through a process of rethinking how we take care of acute and chronic pain in the new era. It's really cool. There's a lot of people involved in it. A lot of people are really excited about it. And one of the health systems that I think many of us look to as the model we should try to emulate are the VA and the DoD healthcare systems that are in the process of implementing this stepped care model throughout all of their clinics, throughout all of their environments. But I love showing this last slide here. Look at all the non-pharmacologic therapies that are now reimbursed by the VA health system. All these things that, again, I will say one more time, I think it's the third time, just in case you didn't hear me, I'm old. When I was trained, I couldn't imagine that 30 years hence I'd be sitting up here advocating acupuncture. I mean, Rick Harris did that to me. But acupuncture, Tai Chi, meditation, yoga, these things that we were really dismissive of, especially in Western medicine, 2, 3, 4 decades ago, with the initial funding of what was initially NCAM, the Complementary and Alternative Medicine Institute. It's now NICI. There really has been good science and good data that have helped move these non-pharmacologic therapies really more front and center. And I can tell you, because I've been involved in some of these processes, the VA didn't move to this model because they just thought it was a good idea. They moved to this model because this is where the evidence is. This is where the evidence sits now, that we really should be integrating behavioral health management into all care of chronic pain patients as well as we possibly can, and making available a broader set of non-pharmacologic therapies early and often so that we don't have to use opioids, and for that matter, we don't have to be as reliant on drugs as we've historically been. So I'm going to stop there. I will take a couple questions, but my talk was really meant to be more of an overview. I guarantee you every single thing that I talked about today will be covered in more depth by someone else, especially Jill, who's speaking next, who is a real primary care physician that really does in clinical practice what I have just said people should do. It's easy for someone like me that doesn't practice anymore to say this is what you should do. That's why I'm going to turn it over to her, because she actually does do this and can do this. Yes?